can keep themselves muted, I'll police that as well. And then we'll get started. So we welcome everybody. I see we have some new people on from our membership, which is good. So just a little background. At the last Thursday of every month, the Healthcare Coalition tries to do a fireside chat. Sometimes they get canceled because, you know, our guests are busy and so on. But we've had, we've had a lot of really interesting topics over the years, over the last 2 years, actually. And they are recorded. We do have a collection of recordings. And those of you who know from last week when we did all the training, we have the trainings recorded. We do have some issues with people accessing Dropbox and stuff like that because of IT problems. So as we continue to try to figure out how to manage that, Kristi, it was like we uploaded Dropbox, we sent out links, nobody could get anything through the links. I sent out QR codes to the Dropbox, and people were like, I got the QR code, do you have the link? I'm like, we already sent the link, and here's the link again. And but the IT departments, they lock, they just block Dropbox. So it's really hard to try to figure out. So the next thing we're going to do is we're going to start our own YouTube channel, a private YouTube channel for our members, and see how that works. I know Kevin's on. It's Avera is usually the biggest culprit in blocking everything that comes in. We're working on a couple of things. We have a new employee now, so she's going to be doing our social media presence and our YouTube channel and all that other stuff. So it's not just me anymore. We're growing. We have more members. We have an employee. It's good. Life is good. So anyway, for those of you who do not know, Kristi Sanger is the Associate Executive Director or co-executive director for AHEPP.
I do all of the grunt work, really not that important.
Right. So Kristi is the face of AHEPP. We'll just, like when you think AHEPP, you think Kristi Sanger. Keith is there, but he's kind of just Keith. And Kristi is, she's the face of AHEPP, and the Healthcare Coalition has a very long relationship with AHEPP. I think since its inception, we've been friends with AHEPP, and we've done work with AHEPP and so on. And recently we were the first guinea pigs for the AHEPP Healthcare Emergency Management Certification process. And so I asked Kristi to come join us today, because we have a lot of new members anyway. To start out, we're going to just kind of do this, like, as you guys know, firesides are not rehearsed, so we have no idea where it's going to go, but it's a friendly conversation. And so the first, I'm trying to remember going back. Well, let you add your own, bio back, first, and then I'll go back to my first question, and then we'll get kicked off.
Okay, so you want me to just tell a little bit about myself, right?
A little bit about you and how you got involved with AHEPP, and
okay.
And the sad story of how Greg roped you into this fireside chat.
All right, so I have been, so my background is definitely healthcare. I have been part of the healthcare world since before I even graduated from college. Ironically enough, I grew up in the Sioux Falls area in Brandon. Both my parents worked in healthcare there. My dad worked for McKinnon. I know you guys don't use that word anymore, but McKinnon Hospital is where he had his entire career. My mom worked at Sioux Falls Surgical Center, which is also a word you guys don't use anymore. But my first experience and glimpse at healthcare was through my parents. And then my mom said, hey, maybe you should work as a nurse assistant in the surgery center. So I worked at the Sioux Falls Surgical Center in the recovery care unit. And so that's where I kind of got my first taste of taking care of patients. And then I went on from there. So I got my degree in laboratory science, So I worked in the lab, and my career took a few unexpected paths, and ended me in infection control about 20 years ago, maybe a little less than that, 18. Let's go with that. But so I was in infection control, and back then, infection control kind of was about one of the very few kind of quality roles in the healthcare within the hospital, and especially if you work for a smaller facility, which is what I did. And I kind of got pulled in, other duties as assigned. Hey, can you help us with this drill? Hey, can you help us do comply with our Joint Commission by running a drill? And it was infection control based. So what did I do? I took our flu shots and said we gotta vaccinate everybody within 24 hours because we're gonna pretend it's anthrax or something crazy. And that's kind of how I got my taste of disaster preparedness. And then after that, I moved into working at the University of Nebraska Medical Center, and my job, my role was, when I was hired, to start running disaster drills with healthcare facilities across the state of Nebraska. And so the state, with some of the post 9/11 dollars, gave money to the University of Nebraska Medical Center as basically a fund to help the entire state, kind of like your South Dakota Healthcare Coalition does now, to do exercises and do training to get everybody more prepared for any kind of event. And so once I started doing that, that was 15 years ago. And I have been ever since working for the University of Nebraska Medical Center. And about 10 years ago, I was bugging all of my colleagues and frustratingly asking them, where is AHEPP? And for those of you that are familiar with infection control, AHEPP is the Association for Practitioners in Infection Control. When I started in infection control, they were my lifeline. Those were the people that I asked all the questions of, and those were the people that I needed when I needed help. That's where I went. And so I kept saying, where's AHEPP? Where's the AHEPP for disaster preparedness? Where is the AHEPP for our disaster professionals? Because this is a job, and we need help. Like, we need to ask each other. We need to work together. And, my colleagues just kept saying, Kristi, there isn't one, get over it. Stop bugging us. Go do your job. And eventually, Keith and I pined over it enough that we said, okay, you know what? This isn't a thing, but we need it. It's needed in the field. Let's start it. And so we did that, and that was 10 years ago, and AHEPP has grown over the years. Obviously, we took a dip in growth, just like everybody else did during COVID, even though, we wanted to help, and we were, collecting and gathering and connecting, and everything that we were doing was useful during COVID. It still didn't help the fact that, nobody had money for an association. Nobody had the dollars to travel, and nobody could travel. It was, and truly, budget within an association like this are always tight. And we rely heavily on sponsorships and our annual conference to kind of pay the bills and keep the lights on. And so we've had slow growth, but growth nonetheless over the years. And I think our new certification program is really putting us at another level. And people, I'm hearing interest from people that I've never heard from before. There's just so much happening right now within AHEPP that I'm just really excited to be part of this organization and to help see what it's going to do in the future.
And you brought up an interesting point, because our healthcare coalition was kind of on an upswing prior to COVID hitting.
Hmm.
And then it crashed and burned horrifically in the first year of COVID for numerous reasons, but mostly because most of our members, like most of your members, are have multiple roles. And so we were called back to our facilities, and the coalition here at that particular point in time was not operational support at all. We've made a massive transition over the last couple of years into what we do now. But interestingly, your story is kind of the same as when I came to South Dakota, and when it was Sioux Valley before it was Sanford.
I remember.
And I went to my first South Dakota Region 3 meeting, and I looked around the table and I saw other Sioux Valley people just because they had shirts or jackets or whatever. And I was like, why are we not all together, like in Sioux Valley? Like, there was a regional meeting, but I think that when I came out, we were starting to talk about just generic surge. There was some HPP rule about being able to surge up to like 500 in the state or something like that, like 100 years ago. And then we started doing H1N1 pandemic flu planning, or H5N1 planning, which was the first one. And I was like, so I called all these people from all these little Sanford hospitals or Sioux Valley hospitals. So we need to have a group. And we actually formed into an emergency management committee, and then ultimately what we called an incident management team. It really wasn't, but we had cool jackets. And there's some people on the call today that's probably still have a jacket. But we we kind of went from there, and then we got more involved in the coalition here. And then I know you and I have been talking for 10 years at least, about, I spoke at your first conference in Omaha, but we've been talking about what is the difference between a healthcare emergency manager and I still don't even know what to call them. I just call them jurisdictional emergency managers now, like biblical NIMS emergency managers that are like county emergency managers and so on. And and there's a couple of things. Healthcare coalitions by trade under ASPR rule are designed to help healthcare facilities plan and create plans, but ASPR also has a kind of a caveat within the rule that states healthcare coalitions are only operational support if the jurisdiction they're in defines that. So when I spoke at I think it was your conference, whatever, in Florida, healthcare coalitions don't have operational authority. Like, they can't do operational support. It's right in there on their healthcare coalition website. So part of that creates this, what is emergency management then in healthcare? Like, what do healthcare coalitions do? And it puts the onus of healthcare response back on the jurisdictional emergency manager, who gets, like, as I put it when I talked about it, was like, how many people in the room are emergency managers? And the hands go up. And how many of you are responsible for ESF8? All the hands go up. And how many of you know how our hospitals operate? And no hands go up. So the argument, I've made it, is the healthcare emergency manager needs to know the jurisdictional emergency, like the NIMS doctrine, emergency management. But there's more. And that's kind of what led to sitting on some of the professional development work. Even academically, most of the academic programs are focused on jurisdictional NIMS doctrine work and not what really occurs in healthcare during crisis. So there's a bunch of these 2-day trainings that are given by a multitude of organizations that say, take this training, you're an emergency manager. So, which I'm leading up to my question now. How does the in defining the standards, the professional standards now, how do you think that changes the paradigm? What's the paradigm shift with now we're going to have healthcare emergency managers?
Well, so that if you're familiar with AHEPP at all, since its inception, our tagline, our mission is always been to move preparedness forward. That's what we always say. We're moving preparedness forward, and moving preparedness forward to us means that we want healthcare emergency management to become its own role. And why? Because there is a difference. Greg, you're spot on. I mean, that's so apparent when you start talking to a healthcare emergency manager and a jurisdictional emergency manager, what you just said. They are different. They're different. And yet healthcare emergency managers are expected to know so much. The knowledge, the amount of information that a healthcare emergency manager has to have stored in their head or know where to go to find it is astonishing. And truly, when you bring up the professional standards, that is something that really there was a light that shined right on us when that happened. When we put together the professional standards, the realization of how many things a healthcare emergency manager is expected to know is astronomical. And I think, don't get me wrong, a jurisdictional emergency manager has to know a lot too. They need to know a lot about different things though. And I think one of the main differences is that healthcare runs as a business in almost every setting. Long-term care, hospitals, ambulatory surgery centers, the urgent cares, they are businesses. They are running as a business. They may not be for profit, but they have to have the bottom line always in mind. There is no government agency that is going to bail them out of, insufficient funds. There is no government support when it comes to being able to manage disasters unless there's a federal declaration. And obviously there are exceptions. Yes, you can have the federal emergency and then you can apply for that money, and then that money comes back from the government, who knows, 10 years later. It's still, by that time, you're under, right? Mm-hmm. So I think a healthcare emergency manager has a different job in the fact that they are always pushing for something that could happen, and yet the budgets are always in mind when it comes to the leadership at the facilities, and they are not on the top list of priorities ever. And so the amount of knowledge and the amount of expertise that has to come from a healthcare emergency manager isn't just ICS. It isn't just how to manage your surge. It isn't just how to train all of your staff in an evacuation. It isn't all the stuff that you need to have and the things that you need to be familiar with when it comes to purchasing things that could bail you out of some really bad disaster. But in addition to that, a healthcare emergency manager needs to know how to talk to administration, how to do a cost-benefit analysis of disaster preparedness versus non-preparedness. They have to be able to interact with the folks that have the resources, and not just the worker bees, but the management. You have to talk an emergency room manager, whoever is in the lead of the emergency room, to be able, you have to talk them into letting some of their staff be trained in decon. So you need to have negotiation skills. I mean, because there's never enough time, there's never enough money, there's never enough hours being paid to staff to allow for that preparation to happen. And you know, a healthcare emergency manager really does do a lot of negotiation. So
It's it's
it's
definitely
hard.
it's definitely a political position as well.
Yeah.
Um, and you made a quality point in the value in identifying the value of a healthcare emergency manager. And I think still to this day, there's a lack of understanding as to what a healthcare emergency manager actually does. And like budget wise, they're the first ones to go. Like, so right now we're looking at a national downtrend because what happened during COVID was obviously all this federal money came in and surged hospitals with money and backed them up. And then the federal money stopped and the hospitals are all in a crunch again. And I hear from my emergency management network across the country that programs are being cut, and so on. And so, but one of the things that we need to lobby for in professionalism and even in our own world is, and it's a hard lobby. It's value added. You don't know. I always tell this story. When I first came here, there was a safety officer, this guy Tom, and we used to go to lunch and used to take us 20 minutes to leave the hospital because he would fix every rug and put every wheelchair away. And what he was doing was preventing accidents, preventing trip hazards, and so on. And I used to pick on him all the time. But I always use him as an example, is that nobody really knows how much money Tom has saved the organization by eliminating the trip hazards, because the trips
Yep.
don't happen. And it's the same thing with preparedness. If the emergency manager's role, and I think the word emergency and disaster is the wrong word, we are crisis managers. I think that's one of the biggest differences, when we look to lobby C-suite, is C-suite thinks in crisis. They are, they take a crisis, they say, how do we fix it? They fix it, they move on to the next crisis. And that's what we do. So a lot of times, a lot of the emergency managers on this call, the healthcare people on this call will know that they don't even get called for half the stuff they should get called for. Like, and I did a goof on that when I spoke at AHEPP last year, like, with the guy looking around the door going, hey, I'm here. And that happens to all of us. But I think one of the biggest issues is trying to get C-suite to understand that the value that we bring is that the more prepared they are, the faster response occurs. And we're moving into operational status, but we're mitigating as we go, and reducing impact. Having the ability to fire up a command center quickly, decision make rapidly, bring people together in a rapid fashion takes all that work that you just brought up, like all of that lobbying and getting the nursing staff to catch on and say, hey, we don't want to be more important than you. We're here to make your job work, and our job is to bring all the pieces together for the decision makers, kind of thing. So as you look
Yeah.
at I have the AHEPP standards up on my other screen. So as you look at the standards, that's exactly how those standards work. Like compliance, that's the number one thing. And if you had an opportunity to look at some of the training that we did last week, it was really based on creating, planning, operating, maintaining. And what we're trying to do is, I get a lot of phone calls from our emergency managers across the coalition. I am in this role. I have no idea what I'm supposed to do. And so we're trying to put something together, but we tried to put something together that they could use that training and go back and get more ready for the AHEPP test at some point, bringing it all, synthesizing it all together. But compliance is a big thing. Coordination with stakeholders in and outside of your organization, in and of itself. And then down the line, exercise design, hazard vulnerability. Let me get my words out. Response ops, and then some of the more recent hotbed issues like social determinants of health and diversity and inclusion and stuff like that. And there's big projects going on all over the country. So I think that from this perspective, it's definitely going in the right direction. So how do we, is that another big question for you? How do we continue to sell the importance, A, of the healthcare emergency manager, and B, of a certification that defines the profession in and of itself? It's not just an add-on tool to a different position. You know, we have quality people, lab people, maintenance people, everybody. It's fragmented. How do we sell and change?
Well, I mean, and you're spot on. I mean, when it comes to sell and change and talk about how to professionalize this field through certification, the only word, this is how every profession has kind of taken it to the next level, by allowing an avenue for folks that are well versed in the field, know their stuff, have been in the field for a long time. They're the go-to mentors, right? Find a way that they can get certified, and how they can get to a point where not only, and this is one of the driving forces within AHEPP always, but especially within the certification. And I'll go into that a little bit further, because those of you that participated in our first round of certification, there's been some changes. There's been some updates within the committee based on just this conversation. Well, not this conversation, but conversations like this, that have been happening within the committee and the members. So what we've been doing is really baking into the certification some requirements for those people that are at that highest level to prove and or give us professional contributions to the field. Because Greg, you've been in this field long enough, and you have historical knowledge of anything and everything that you come across in your years of reacting and responding and preparing for all of these healthcare disasters. And when you retire at some point, maybe if you retire, all of that historical knowledge and all of that helpful insight either is out there in the world to the next group of people, or it's gone. And what we want within AHEPP, and what is our priority within AHEPP, is we know there's a ton of people like Greg Santamaria out there that have been doing this for a long time and have that historical knowledge and have all of the things that everybody that is just fresh coming into the field needs to know. You are the experts, and we need to find a way to make sure that knowledge gets continually passed down to the next generation of emergency managers in healthcare. And one of the ways that we're going to do that is through our certification program. So we have a few different levels within our certification program: basic, professional, and mastery. And the basic is for those folks that have been in the field for 1 year. They want to prove that they have the knowledge base to do this job, to an employer, to whoever. Ideally, like, our hope is that at some point we would love to have hospitals expect that upon employment, to say, hey, by the time you've been here for 1 year or 2 years, we expect you to be certified through AHEPP, because we know that they've done their homework. They have built the professional standards according to the way a hospital really runs, and we want you to be knowledgeable in all of those professional standards. That's our goal. I think that truly will professionalize this entire field if we can get to a point where this is kind of proof of knowledge, proof of concept kind of thing. But then the mastery level, those mastery level applicants, those are the 10 plus years of experience. Those are the folks that have been doing this and have been running exercises. They've been taking command within their incident command. They've probably participated even in unified command within their healthcare organizations. There's a lot of experiential knowledge that they have to offer the professional field. And so when we talk about professional contributions, one of the things that we've added to that mastery level component is that we expect that anybody that's applying for that mastery level to either have already done a presentation of their own, not just like I just taught a FEMA class that's already been created, a presentation of their own on whatever professional standard that you want. And we have a lot of professional standards. Pretty much everything within preparedness fits within our professional standards. And if it doesn't, in a year or two, it will be there, because we have plans to add more competencies based on all of the things that are coming at us all the time. I know business continuity is top of the list. Like, that needs to be part of the professional standard, because that's part of the requirements within your compliance organizations already. But things are ever changing. That's why we love this field, right? And so so that professional contribution would be a presentation to an audience to share your knowledge. And maybe that happened years ago and you can say, yeah, I've done that already and I qualify, and you submit your documentation, but maybe you haven't done that. Maybe that's a goal. Maybe that's something you're planning to do, as if you want to get this mastery level certification. And AHEPP has a ton of avenues to allow you to present, live conference, webinars, everything else. So does NHCPC. Many of you probably attend that conference. I think it's in Las Vegas this year. Oof, that's going to be crazy. And there's a lot of like state organizations where you can present your knowledge and share your knowledge, or you could potentially write an article for a peer-reviewed journal. But some kind of professional contribution is going to be part of our mastery level certification. And it's not because we want to be mean. It really isn't. It's because we want this field and we want this knowledge to be perpetuated. And this is one of the ways that we feel that AHEPP can help do that. So that's what we're doing. And back to your crisis management statement, I thought that was a very interesting statement, because one of the things that we tried to do within the agenda for the upcoming annual conference, is build in some of those, like, not just, oh man, there's a tornado and it wiped out the town, but other things that are part of the worries of a disaster preparedness professional. And so one of our keynote speakers is going to talk about construction and the construction process that turns into a disaster. I mean, and those are the things that you can convince your C-suite. Like, show me a hospital in this country that isn't under construction. I'd be shocked if I find one. And construction is always a quick way to end up with problems within the facility that either take your power out, give you a flood, all of a sudden you lose your lab, whatever it is. But those are things that when it happens, the expectation is not that facilities takes care of that. They come to you. They're like, oh, we lost power, now it's a disaster.
Right.
And yet when push comes to shove and the budgets are being created, they say, well, we haven't had a disaster. Well, yes, you have. You've had to respond to multiple things. So my biggest advice for anybody that cares to listen is count those disasters. If you are trying to convince your C-suite that you're needed and this position is worthwhile, every time they come to you with a problem, document it. If it's worth it, if it's big enough, write an after action report. And when it comes time to justify your position, show them all of the things that you've reacted to, all of the things that you've helped them get out of a pickle with, and work towards that. And it's interesting. We have a new-ish tools and resources committee we started within AHEPP. And one of the things that this Tools and Resources Committee wants to do is create a bunch of tools for our membership, right? So we want to make sure that, you know, if somebody's using a unique incident command something, in fact, one of our things is an IAP. They've altered their IAP to make it more user friendly for healthcare, right? But still compliant with the federal government and being able to submit that for reimbursement if needed. But somebody within this group has been using this at their facility, and they showed it to the rest of the group, and the rest of the group said, wow, I'm going to start using that. Wow, I'm going to start using. So if I showed it to this group, they'd all say, wow, I think I want to use that too. We're not trying to invent things that aren't needed. We're just trying to share things that other people have found useful. And so one of the tools priorities, the tools committee's priorities was, and this is the most odd request that I would have expected out of this committee, but they wanted a job description, an emergency manager, healthcare emergency manager job description. That was their first project. That was their first priority, because every single one of them was having to justify their position at the time. And coming back to your statement about people are trying to make cuts, they are. And so for us to be able to continue to highlight and show people that healthcare emergency managers don't just deal with the tornadoes and the hurricanes. They deal with a whole lot more, and they save the facility a whole lot of headaches and money. If we can make sure that that is highlighted in everything and anything you do, especially when you have a conversation with your leadership, I think that's going to guide the entire profession into a higher level as well.
And you made a couple of key comments here. So the term crisis, getting back to the term crisis, I changed when I was with Sanford, I changed the definition of everything, and I was like, crisis, we activate. So instead of disaster, we're crisis management. Crisis is defined as anything that happens outside of regular business that affects regular business or impacts regular business. And even the change of the incident command model, we went to an ESF based model, and because with an ESF based model, you're not taking a C-suite exec decision maker and throwing a vest on them and saying, now you're this person, because they take the vest off and throw it back at you, and they do it anyway. And you've heard me, I'm kind of like the anti-NIMS guy. Like, I believe in that structure. However, I believe that structure has a place. But NIMS, the doctrine in and of itself, says you don't change what you do every day. And then we take healthcare execs and we change what they do every day. And we're like, oh, you're this, you're that, you're that. An ESF model is a little bit different. So if you can restructure the ESF, the 15 ESFs and add ESFs, there's no law that says you can't only have to have 15. But what I did is we created an ESF based model, and then we had a checklist. If this incident occurs, we activate these ESFs first. And then I met with each exec who was going to be the lead of the ESF, said, here, give me your number and your backup person's number. And when you get this call, you just need to come to a room and do your job. I'm not giving you a job description. I need you to do your job. So if you're the supply chain guy, you're in charge of all this stuff. If you're the HR guy, you're in charge of all of that. And it transitioned well, and it worked. I think that there is a thought, like, if the emergency manager does their job right, the command center can operate without them, but the organization can't operate without them. So if I'm not there, and I'm somewhere else and an activation occurs, the entire team should be able to come up. And my job is to make it that good. And our job, everybody here and is to make it that good, and our training makes it that good. But our job is also to follow trends and change plans based on after actions and so on. So it's not a job where you can build a plan and then, oh, well, we already know what we're doing, so we don't need this person anymore, because a year later everything's going to change, and there's going to be new trends and so on. So I think that a lot of lobbying needs to occur, a lot of internal marketing needs to happen. And again, we're not revenue generating, we're not clinical, but we are, when you look at, if you do it right, when you look in terms of potential lawsuits for doing it wrong, like if you look at the nursing homes, I think it was during the hurricanes in Texas where there were pictures of people in wheelchairs up to their waists in water. You know, that you did it wrong. You know, you did it wrong. You have people sitting in water, and you know, I use our evacuation in Florida a lot as an example of, like, listen, we moved 240 people, and we were out of there 24 hours before the storm hit, and no one got wet. We didn't have to deal with alligators. Everything was great. And then we brought everybody home and nobody died. So that is you know, the number one job is to keep everybody alive, and understanding the changes in the concepts of preparedness is important. And so that's kind of a showpiece to say, listen, if you do it right and you get out of there in time, it's okay if buildings get wet. It's okay if, you know, it's not okay if people die. You know, there's the collateral loss of life is really an unacceptable loss. Or a salary, for one salary for an emergency manager or a team of emergency managers in a large organization, not just, you know, here, but across the country, where they're getting cut. I know that Mount Sinai is making cuts right now, and I know that they've, you know, your relationship with them is good. They speak at your conference a lot. I know that their department is shrinking and shrinking and shrinking, and so on. And one hospital, just from the other side, one hospital in Pennsylvania just got fined, I believe, $700,000 for not having an emergency manager. So because there was a disaster, so there's this like balance. And then the other thing is, I'm looking at, because you brought this up, I'm looking at the demographics that we took for South Dakota, and I compared them to the demographics that I did when I did my comm program when I was working on my doctoral degree. There's this weird U-shaped curve where the people that have 1 to 5 years experience are up here, and then there's like a dip, and then you have all these people with 10 plus. And it's not like it's not a normal curve, it's a U-shaped curve. And in ours, for the 40 people who did the demographic survey, it's almost a W-shaped curve, where 1 year and 5 year were high, but 40% of the people were 10 years, and a combination of about 20% of the people were 1 year and 5 year. And then there was a dip between 1 and 5. It's really strange, and I don't know. Like, it's something to watch as more and more of these demographics are gathered, to see, like, I'm interested in why, like, where were all the people, like, I think the 10 plus years are explainable. Most of, you know, people who are 15, 20 years out, 9/11 created a big surge in healthcare emergency management. Then it kind of went away. And I think what we're going to see now with this, the 1 year people are being explained by, all right, COVID was another big thing, but I think that this is something to watch. It's also something, another thing that we should be watching is, and I want to get your opinion on this in the last 10 minutes, is the trend of the old guys. And I've said this for a long time. There's a lot of people who've been around for 20 years who don't have any academic background. And now the new people coming in are coming in with degrees in EM, but don't have any operational experience. So it's like, but that gap will go away as those new people come in, work with the older people, but deal with their own disasters. And then you see a more organized profession, because now they're academic, operational people, and they've got this foundational academic knowledge and this, you know, essential operational knowledge. And I see that happening, and I'm a big proponent of it. We just need to figure out as professionals and the people who support professionals how to support that. And, you know, and I think that the master level when you look at, not having a degree for the entry level was essential because we want to make sure we're not excluding people who don't have degrees who have brilliant operational success. And then kind of as I think that the evolution to the master level is something that, kind of supports going back to school, getting a degree in emergency management, and hopefully will prompt schools to create a degree program in healthcare emergency management. There are one or two, but most of the emergency management programs are standard jurisdictional, NIMS doctrine stuff. So anyway, where do you see, like, I'll put you on the spot, but I know you'll do just fine. Where do you see that going? Like, how do you see us being able to do that?
So, that's a good question. Where do I see it going? Yeah, I think you're spot on. I mean, there are more and more degree programs out there. The traditional go to college, then get a job situation is happening more and more in this field. Back in the day, it didn't. Why? Because there were programs. We didn't have that. That option was not there. And so I think, those folks that are getting the emergency management degrees are going to have that academic knowledge. They will be able to apply the concepts that we learned on the fly because they learned it in a classroom. That being said, there is nothing like experience. And for those of us that all learned the hard way, we've paved the way and we should continue to do so. We need to teach that experience. There is a reason that the committee that put together all of the requirements for the AHEPP certification did not say you have to have an emergency management bachelor degree to take this exam and get this certification. And rather, they put in place that you need to have 1 year of experience in a healthcare emergency management role. And that doesn't mean you have to be in a hospital. It means that you have to have 1 year of experience with healthcare emergency management. If you work in a public health department, you've worked alongside your healthcare component and you have that knowledge base, yes, that counts. But nonetheless, experience is still important and prioritized. And truly, if we required a degree, and we don't require a degree for any level, but requiring a degree is one thing. But how much does that mean? I know that there are other organizations that require a degree, but don't say which degree they require. So if I got a master's in anthropology, is that helping me do my healthcare emergency management job? Maybe I know how to write, reports better to my executive team. Maybe I have a little bit more knowledge on, some of the history of, or I know how to do research a little bit better than some of my counterparts that don't have a master's degree. But in the end, do I know the healthcare? Do I know the emergency management field? Do I understand how it works truly just by getting a master's in anthropology? No, you couldn't possibly. And so I think that, the importance of a college degree has its place. I'm a big proponent of college degrees. Don't get me wrong. I have expectations that my kids go to college. I went to college. I have no problem with college. But I do think that, that experience, especially in this field, is really helpful and really goes a long way. And so the certification in general, we created the certification to be part of the tools that an emergency manager has. So if they are trying to get a job, if you are trying to get a job at Sanford, we'll talk about Greg's facility, X facility, and they want to hire somebody, and Greg's going to put his resume in, and he's got not only, a bachelor's degree, but he's got a master's degree and I think a PhD as well. And then, but maybe what if he didn't have the history in his experience with his healthcare emergency management, but instead had a certification in emergency management from us? That's where we come in. It means that we have a way to tell employers that, yes, this individual has been in the field long enough that they have an understanding of the concepts needed to complete a healthcare emergency management job. And if Sanford requires an advanced degree in that role as well, that's up to them. That's great. I mean, whatever. That's not where we are going to verify. That's for an employer to verify. But from our perspective within the certification, the meaning and the purpose of the certification is truly to validate that somebody has the knowledge. Now, we are not validating skills. We have no way of not validating skills. So we are validating that you have the knowledge of the field enough that you should be able to go into a role and really talk the talk and understand what's expected of you. And that's kind of the whole purpose. But every piece of the puzzle has its role, and we only want to be part of it. We don't want to be all of it. So.
Well, yeah, and I think that's important. I know we have about 2 minutes left, but I wanted to share a story with you. Those people who know Scott, who does work for us, and him and I, whenever we get together, we fight, we argue. I would call it healthy debate. And we had a big debate the other day about the CEM versus the HCEM. Because a lot of healthcare facilities, are requiring, you have a CEM, and that I made that comment at AHEPP last year in the professional standards meeting. A CEM does not an emergency manager make. And it came, there were a couple of boos in the room, because I think that there is, his argument was, well, the CEM shows that they have a knowledge in emergency management. And then if they have experience in healthcare and, and whatever, and my argument was, yeah, but the CEM alone doesn't prepare you to be a healthcare emergency manager. Neither does the HCEM, but the requirements that lead to a healthcare emergency management certification are more in tune to that. And I said, and one of the things that needs to happen is, again, you're back to politics, right? Lobbying. Well, why are you using CEM as an HCEM? Like, the HCEM is very specific to healthcare, and you're specifically a healthcare facility. And the people that have the HCEM are understanding that. Like, I looked at the data time and time again with this survey about the knowledge base of people saying, well, I slightly am aware of CMS Appendix Z. I slightly am aware of NFPA 1600. And a good number of folks who signed up for this had very little knowledge of the HPP program. And that's one of the biggest parts of the job, is maintaining your requirements in the HPP program and stuff like that. So it's interesting from that perspective. So anyway, final thoughts. I think that everything's going in the right direction from the perspective of having a certification in emergency management. I think we're finding our way into that realm, and it's a long time coming. So anyway, final thoughts, and thank you for your for giving us some time today and giving us your ideas.
Yeah, I would be remiss without telling the entire group that this entire program, this certification program, has been not created by Kristi and Keith. It has been created by AHEPP members that have volunteered countless hours of time and energy because they believe in this. And so when it comes to validating whether or not, this versus others, and I don't want to get involved. I don't want to promote something and push something that isn't right for somebody. But I will tell you that the folks that are in this field, that are working day to day, that live and breathe healthcare preparedness, are the ones that created this. So they know. They know what's needed in the field. They know what the knowledge base needs to be in the field. And I think that that's really an important factor within this. And it's in general kind of an important factor of AHEPP, the association as a whole. We really, really involve our membership. We really, really listen to our membership. Everything we do is focused and questioned, to the members. We make sure that we are truly listening to what is needed out there in the real life field, because Kristi here in academia doesn't know it anymore. I need to listen. And so, some of the things we do, I take into consideration every time we think about anything with AHEPP. We do the collaborate with colleagues every single month, and I listen to our fellow colleagues talk about their problems and concerns and projects that they're working on. That's how I stay abreast of what's happening in the field, and it's nationally and even beyond. In fact, we have a new Canadian chapter, and the Canadian chapter has about 30 members, which is so exciting. But our next thing on the list is to start applying some of those certification concepts to Canada, and I think we have a lot to learn from them. Even though their healthcare system is different than ours, we can apply concepts that they have been doing. They've been using the U.S. concepts for a long time. So, I think that the field of healthcare emergency management is a field that you cannot do in a bubble. You have to rely on your peers. You have to rely on outside sources for help. I always jokingly say it's not what you know, it's who you know. But it's kind of a joke. It's kind of real. You really do need to get to know your neighbors. If you don't know another healthcare emergency manager, you should meet somebody and go have coffee and figure out life's problems together, because you will be more successful if you can collaborate. And that's what AHEPP is all about, collaboration.
And that's a great final point. Is networking is essential. Like, conferences, going to conferences and meeting people. You'll always find me probably outside the lecture hall, rather than inside the lecture hall. Picking someone's brain, or someone's picking my brain, and whatever, and exchanging business cards and ideas and so on. And I think that is it's not for everyone, but I think that's what makes the profession better, is that when you start talking to people from California or Oklahoma or Ohio, you find similarities in the issues that you're facing, and differences in the solutions to the issues. So I think that's a key takeaway from this, is like networking is one of the most important things. We don't work in a bubble. We're all facing the same crisis, and the same problems, and the same requirements. I am so excited that all these long-term care facilities are jumping on board, like skilled nursing and assisted living. And it's like, I saw all these people, and I texted the director of rural health, who is in charge of the HPP program, like, Caitlin, you can't believe, like, she's an ex skilled nursing administrator. You can't believe how many more skilled nursing facilities are part of this now. And it's little victories like that that enhance preparedness across the board. So more to come. Thank you so much for your time. I really appreciate it.
Anytime, Greg.
On behalf of our members, thanks for coming, and we'll get this posted as soon as we figure out how to get it out to people outside of Dropbox. It'll be great.
Sounds good. Well, have a good day all, and stay warm on Halloween night.
Yep. Take care. Have a great one. Bye-bye.
Bye.